Aditya, are you there?
Hello, good afternoon.
Hi, Arundhati. Are you showing your face?
Yes, I shall just try. Oh, it's saying that I cannot start my video because my host has stopped it.
Wait. I'm just doing that.
Oh my, Aditya, what are you doing? Well, I dread this part of showing my face. I think this is the first time in the last 7 months I've actually put a sticker in front of my video.
Can you try now?
Yeah. Oh, yes.
Hi.
Showing up. Hello.
Finally, to put a face.
Yes, nice to meet you. Nice to meet you. Sorry, I shall tie up my hair. Hello, Aditya. How are you?
I'm good. Just making all the other arrangements. Just checking.
Super, thank you. We could not have done this without you. So thank you.
Aditya, just can we play? Can we put on my PPT and just play the part for Val's video? I just want to see the sound comes well.
Okay, sure.
And I'm going to turn off my video. And I think that we have Sophie. Welcome. Thank you for joining us. I hope you can hear us. This is Arundhati.
Hi, Arundhati. Hi, everyone. Yes, I can hear you.
Great. Welcome. Thank you for joining us.
Thank you. Thank you for inviting us.
We're just looking to see if a particular video is playing well. And then, Sophie, we'll just do a quick video check with you just to make sure that everything's in order.
Can you, sorry, Aditya, just go to the slide number 7, click on that, and then do the full screen.
Yeah, I'm just.
The topic I've become most excited about over the 30 years that I've worked with the London School of Hygiene and Tropical Medicine is that of behaviour. But when I first started working on it, it really wasn't
I think it's working. That's fine.
Or discussion.
I need to check one more.
So I just want to check. We seem to have three attendees. It's showing me, but I can see 2. Just wanted to check that.
Yeah, it's the same for me. I'm actually seeing 2 attendees, but there are 3 of them. Okay, thanks, Aditya.
So Sophie, could we just have you put your video on so that we can quickly check whether that works and say hello in person? Hello.
Let me just adjust it slightly and switch off the light, maybe.
Sure.
That's
great.
Better.
Yes, we can see you clearly now, Sophie. Thank you. And Sophie, just to check, do you have a presentation?
No, I don't. Sorry, I didn't.
Not a problem.
To prepare.
No, that's not a problem. We just want to make sure that we if anyone is using one, then we have it ready. We just wanted to double check. It's absolutely fine. We want to keep this a little conversational, so it's great.
Okay.
Sophie, also with us are our co-hosts. There's Kaushiki Banerjee from UNICEF India and Aditya Jain, who's also with UNICEF, and our colleagues from IRC will also.
Hi, Sophie.
Hi, everyone. Nice to meet you.
Tie up my hair. Good afternoon. I see that Shiny, hello, welcome. And Jairam ji, you've also joined. Welcome. Good afternoon.
Yeah, good afternoon. Thank you.
Great. Jairam ji, can we just ask you to show us your video just to know that we can see you clearly? We don't have to have our videos on at all times, but when we're speaking, it would be good for the audience to see. So if we could just have you.
The message is coming, you cannot start your video because the host has stopped it.
Right. So
you have to
then,
give the permission.
yes. So I think.
Can you just check, recheck now?
I think it's coming up.
Yeah, I think now it will come.
I think I saw Ingeborg also come on, but then she's no longer on.
Okay.
Yeah, she dropped out, I think.
Okay. Well, the good thing is that means she can log in. So
That's good. Jairam ji, we can't see you as yet.
Yeah, I have switched on the video. I think.
No worries. No problem. Yes,
Yeah.
we can
Is
see
it
you.
coming
Yes,
now?
yes. Absolutely. Yes, absolutely clear. Great. So now we know we can see you and we can hear you also clearly. Thank you for that.
Right.
Okay. Can you also hear me?
Yes. Ingeborg, welcome.
Yes. Thank you. Sorry, they keep throwing me out.
Oh no.
I hope this will stay, and I'm trying to see where I am. Am I also showing my video?
If you could just show us your video right now, your video is off, but if you could show it to us, then we'll know we can see you when you're speaking.
Okay, let me see if that is.
So Arundhati, Aditya will be projecting our PPT, right?
Yes,
Yes.
Aditya is here, so he will be.
Right, that would be great.
And I think Aditya, Robert seems to be having a problem. Oops.
Ingeborg, can you just turn on your video once so that we can see?
Yeah, I'm trying to get. Oh, that's a pity. I don't have my hygiene background here. Let's see. Video.
Arundhati, I have forwarded the request to Robert. Hopefully he'll be able to join.
Oh, super. Super, thanks, Kaushiki. I see, okay. Anita has joined. Good afternoon, Anita ji. And Dr. Saurav, you have also joined. Good afternoon.
Good afternoon.
So, good afternoon. Anita ji, could you just show us your video and Dr. Saurav, you as well, so that we know that we can see you. We don't have to keep the video on, but just when you're speaking, then see. Yes, Dr. Saurav, you're visible. Thank you.
Okay, yeah, for some reason I can't turn on my video.
Oh no. Anita ji, we can see you very clearly. Thank you.
Okay, thank you.
Perfect. Great.
Aditya, can you check Ingeborg's video?
Yeah, just checking. Can you just try to reconnect once? It might be some other problem because from my side it's all clear.
Okay, now it is.
Oh, it's yeah. Yeah.
Okay, thank you.
And I think to our audience who's already joined, we have 16 people who have already joined. So welcome. Please do give us another 10 minutes. and then we'll get started. Thank you for joining us.
Aditya, Arundhati, I think Robert is still having some difficulty joining the link, and I just shared out and I've copied you in the email as well.
Okay, I will just check.
Yes, so I think, Aditya, I think we're all set here because all our other panelists, Anita, Dr. Saurabh, Ingeborg, Jairam, and Sophie all seem to be fine. We can see them. They didn't have any issues accessing. So if you could just help Robert, I think that would be great. But otherwise, I think we're all set at this end.
Yes.
Are we missing Sumit as well from Niman?
The link is working fine. I don't know.
Okay.
Sumit has just joined. Good afternoon, Sumit.
Hi, how are you? Is it Kaushiki?
This is Arundhati. Kaushiki is there.
Oh, hi. Yeah.
Hi, Sumit. Sumit, can
Hi.
we just have you on video just to know that we can see your face just when you speak?
Can you
Yes.
see me? Is this okay?
Yes. Yes, there's a little bit of light, but I think otherwise we can see you very clearly.
Let me try to shut this light then. Okay.
But otherwise we can see you clearly. Thank you.
Okay, great. Thank you. Yeah.
Robert, you've joined us. Good afternoon. Good morning.
Hi.
Hi, Robert. Would you be able to just, yes, we can see you as well. Sorry,
Great.
you had some difficulty. I hope it's smooth at your end right now.
Yeah, no problem.
Great, thank you. Thank you. And do let us know if you have any other problems with the connection.
Okay, yep.
So we'll wait for another 2 minutes or so.
Yes, Shiny, I think that's good. We can start in another 2 minutes. Kaushiki, will you be able to check when Nicola will join?
Yeah, I'm on it.
Welcome everyone. We'll start in another 5 minutes. Thanks for joining us.
Hi, Nicola, are you there? Nicola is joining in next 2 minutes.
We'll start in some time. We're just waiting for one of our panelists to join.
Shiny, why don't we go ahead and start start with the Mentimeter, welcome and Mentimeter, and then we'll get on to Nicola's opening.
Okay. So, good afternoon, everyone. Good morning to our panelists joining from overseas. Welcome to the final webinar of the 3-part Global Hand Washing Day webinar series. We've covered a range of topics from technology and innovation to behavior change, and today's is on measuring hand washing with soap. We have planned an interactive voting tool on Mentimeter. So if I could request you all to go to www.menti.com and use the code. Aditya, can you go back to the previous slide? Yeah. Yeah. If you could just follow what's being shown. Yeah. Just Menti.
I'm just sharing the link.
Yeah. And use the code 772424. For those of you who are not familiar with this tool, it's a real-time interactive voting tool which is completely anonymous. So Yeah. Think we can start. Aditya, can we see how many people are there, or should we?
Can we go to the first?
Yeah. So the first question is something to know you better. What drew you to this webinar? Interesting. We have some people who are interested. Oh, we have equal number of people interested in, or now more of M&E people than hand hygiene. And good to see there are some who've been asked by their supervisor. Yeah, we've all been there. Both of my supervisors are online, so. Okay, I think most people are interested in what it seems like in M&E, and there are equal number of people interested in hand hygiene. Let's move to the next question. What do you expect from this webinar? Okay, so many of us want to learn about hand hygiene monitoring. Great. Next question, Aditya. What is your role in the organization that you're currently working in? Oh, we have quite a few of others. Interesting. Okay. Let's go to the next question, Aditya. So now we have a few technical questions. If you could only measure one thing in a hand washing survey, what would that be? Access to water and soap, presence of a designated space to wash hand, knowledge of why, how, when to wash hands, or frequency of hand washing.
We also have some participants raising their hands. So maybe once we are done with Mentimeter, we can take a quick round for question. And please do participate because we only have 36 people right now showing using the menti.com.
Okay, so most of us think access to water and soap is the most critical thing to measure in a hand washing survey. Interesting. Okay. So here's a maybe we do not show the results right away, Aditya, then, and you stop sharing your screen and we come to it when some people have already answered in, say, about a few seconds. Otherwise, this is influencing. Yeah. Let's look at the results for this one. Okay. Frequency of hand washing. Good. Seems like the predominant one. Let's maybe go to the next question and yes. And you may stop sharing your screen till the time some results come in. Yeah. What is the source of hand washing data that you frequently use?
Let's go to the.
Yeah, maybe we look at the results now. Most of us use demographic surveys and program MIS as well. Okay. Next question. So, yeah, this is the gaps in data on hand washing in India. Interesting to see that reliability appears to be the primary concern with regard to data. And we have some other concerns as well. Lack of good monitoring, attitude and behavior, of system authenticity. Great. So thank you everyone for this fun exercise. Now, if I may invite Nicola, the Chief of WASH in UNICEF India, for some opening remarks.
Sure. Hi, everyone. Very happy to be here. I'll try to be short because what matters is what comes next discussion we are going to have. For this, I mean, the COVID-19 pandemic is a dramatic issues affecting a lot of people. But one of the opportunities it brings is this unprecedented attention to hand washing with soap. And somehow COVID did in 6 months what we collectively have been trying to do in decades in raising that the awareness on hand washing with soap. And we all know about how hand hygiene is one of the most cost-effective public health interventions, and much beyond the issue of COVID. It's for waterborne disease, and also it contributes to prevent respiratory disease and infections. So, of course, as we all collectively try to push for hand washing with soap and embed it within the flagships of the government of India, because this is how we can reach the scale, and especially because the current period is really good with 2 flagships on WASH, JJM and SBS phase 2. We need to really have that attention on monitoring systems to inform programming and to make sure that we have the best information to inform at central level and in states level. So yeah, I mean, the practice of hand washing requires a functional hand washing station and with a place with water and soap available at all time. And of course, the knowledge on why and how and when to wash hands to make the best of this preventive measure. And it's not only about household level, it's also very important for key institutions such as schools, health facilities, and for UNICEF standpoints, all the institutions that are important to children. I name a few of them. So just to frame things from our standpoint here, yes, we need to find innovative measures, but also let's face it, measuring a practice and a behavior, it's something a bit complex. There is a lot of research and a lot of people have been working on that, and we can learn from others and we will hear from the panel. But monitoring a behavior at scale is not an easy thing. So I guess collectively we need to find the right balance between a mix of indicators. And I think the main one that we use, WHO and UNICEF, it's this proxy indicator to observe the ability of a hand washing dedicated place or station with water and soap available. And it's not about the practice, with more qualitative approaches to nuance what we can observe at scale here. So again, I hope we can discuss this mix of accepting that, you know, this proxy is still an indication, and when we are in India, by the ongoing times, we need to think about the scale and nuance that with more qualitative approach, and we'll talk about it, immersion studies and or technical innovation, smart soaps. Let's see, I mean, we don't need to reinvent a lot. It's more about finding what would work in India using the global experience, and there is a lot out there that we can use. And so this will be, in any case, what will be reported globally, and I think also at the national level will come from the MISS and the household surveys, and JMP is going to use this as well. But there are other more detailed solutions at scale. I'm thinking about the Swachh Vidyara Purashkar monitoring system in school that has much more indicators on hand washing, not practices, but supplies and in the enabling environment. But again, not a lot on the behavior itself. So and we'll have also the next national family healthcare survey and other surveys that we can use and influence. We saw the NSSO 76th round as well that look at hand washing, asking questions and also making observations. So maybe we could discuss also what is in those large scale monitoring system. Is it observation or asking question that would work best, and in the context of India, unfortunately in the various contexts of India, because that complexifies our task because we don't have a unified practice and situation here. So a lot of complex issues to address today, but it's important that we have that discussion now and that we continue to collectively look at hand washing with soap programming from all angles and today on the monitoring side. So that's for my introduction remarks. Thank you very much, and I'm very happy to listen to the discussions moving forward. Thank you.
Thank you, Nicola, for setting the stage. And as you rightfully said, measuring a behavior is complex. So today's discussion will hopefully shed light on how we can do it better and how we can learn from each other. Over to you, Kaushiki.
Thanks, Shiny. I hope everyone can see my screen.
Yes, we can.
Sure. So, hi everyone. So I'm Kaushiki from UNICEF. I'm the monitoring and evaluation focal point for India Country Program. So today, what I'll sort of talk and try to set the context is about the global framework and why is it important to measure hand hygiene. So I think initially when we were discussing, the idea is why is this webinar important? Because hand hygiene interventions are happening all over the country, all over the world, and why this webinar is really grounded and why we really need to talk about the monitoring and evaluation part is we really wanted to discuss the measurement framework for hand washing with soap globally and also in India. So that was one of the first objective of this webinar. We wanted to explore opportunities with people, with all our panelists, with all our attendees who are participating in this program to strengthen the measurement of hand washing with soap indicators into large scale surveys, because there are many large scale surveys happening and we really want to see where hand washing stands in that. It's also the third important objective is to highlight the effectiveness and the innovative methods to measure the different hand washing methodologies in the context of programming. And at the end in the webinar, because we're just starting this whole discussion, we want interested participants to join a working group that we are planning to develop and also work on the hand washing with soap framework. So just to start with the hand hygiene, jointly UNICEF and WHO has called for an action on hand hygiene for all. As you see that there is a guideline that we have recently come out with. So within the guideline, I think one of the most important, which is this bit. So there are different components of this guideline and why hand hygiene and how to ensure that there is sustainable hand hygiene practice. Political leadership, hand hygiene behavior, I think behavior change is one of the important components, policies and strategies, and similarly going forward, planning, monitoring, review is one of the building blocks to ensure that there is sustainable hand hygiene practices. Now moving into a little bit depth of it, I think there are three main components of how monitoring and evaluation comes into place. So first point is to respond. These are the short-term response or short-term monitoring and evaluation patterns, like where we are trying to control the outbreak. The second part is to rebuild. This is a medium-term goal where we want to build back better, and in order to ensure that whatever system we are placing in the short term is sustainable in the medium term. And the final point is to reimagine. Are we able to sustain the culture of hand hygiene? We're going to circle back on these three important blocks, which is respond, rebuild, and reimagine in the next bit of our presentation. So if we have to ask that what we are currently measuring, so why we are having this webinar and then what we are currently measuring. So I'll quickly touch upon, and this is something we all have been working, which is the GMP ladder and the core indicators. As per the GMP ladder, the hand washing, we have these three different service levels: the basic, the limited, and no facility, and the worlds are ranked on basis of this particular ladder. When we talk about the core indicators, which is a part of the GMP and mostly trying to draw parallel with the SDGs, and all the countries are trying to put all these indicators somewhere in the national surveys and also at small scale surveys. For household, it is the availability of hand washing facility on premises with soap and water. But it just does not end at household, because I think one of the two most important criteria is to understand hand washing situation in school and also in healthcare facility. So within school, it is a proportion of school, including pre-primary, primary, and secondary. It's important to have these disaggregated data, with hand washing facilities which have soap and water available. And the last core indicator for healthcare facility is healthcare facilities with functional hand hygiene facilities available at one or more points of care within 5 meters of toilet. So these are the core indicators that we really want, and we are also working, all the countries are working to have included in the national and the small scale surveys. So just a quick glimpse on the global data on hand hygiene, and this is the data pre-COVID. So if you look at the graph, we see that 60% is showing the hand hygiene availability. This is basic hand hygiene availability, that is premises, hand washing facility within the premises with water and soap, 60% in household. We kind of see that 2 out of 5 people in the world still do not have a hand washing facility within premises. For the school, it is almost half of the school in the world do not have hand washing facility. And one of the most striking part is that we are actually lacking data within for the healthcare facilities. And if you look at this, only 14 countries had data on basic hygiene. I think this is a major part that we also want to kind of come in and say that there is lack of data. So in order to ensure that there is proper data and there is proper data collection, it's important to have monitoring and evaluation and actually discuss about it today. So just circling back, how do we measure? Because we have spoken about why and we have spoken about what, and then how do we kind of ensure that the measurement of hand hygiene is happening? So the first bit is to think about the national level large surveys, including hand hygiene indicators for household, school, and HCF, and these national level surveys such as NSSO, NFHS, and we also have NAS data. And I think one of the important part is that this is a rebuild. This is a medium-term goal. We can include the data. We can include the core indicators, which is important to measure within this national level large survey. So something we can in the medium term can pick it up. The second point is to explore quantitative research methodologies. And this is something that, the large scale data have been including. And how can we reduce the bias while measuring hand hygiene? Since a lot of our report is we have self-reported data. So how do we ensure that the quantitative research methodologies are innovative and we create more and more innovative processes through that? The third point is to also look at the qualitative research and to capture the sustainable hand hygiene practice behavior, because quantitative data cannot only can give us a lot of idea, but when we talk about behavior change, it's important to have the qualitative component, and we'll also touch upon this in today's webinar through our panelist discussion. The next point is to mainstream hand hygiene data collection in routine administrative data collection system in the large MISs, for example, DDWS, we have MHRD. So in order to, in the context of India, we need to ensure that the hand hygiene data are a part of MIS. And this is something, again, going back to the building block, is a part of reimagining to sustain it. And this is a long-term goal, though we really need to work a lot on this. And I think the short term and something that is quickly happening, and also UNICEF has been working on this, is implementers setting up rapid data collection and identifying the vulnerable population to understand and measure the hand hygiene status currently. And UNICEF recently has conducted a couple of rapid assessments, and there were very interesting results that has come nationally from the country. So I'll just come to the last part. This is the inaugural lecture and a tribute to late Professor Val Curtis from LSHTM. I hope you enjoyed this last lecture.
The topic I've become most excited about over the 30 years that I've worked with the London School of Hygiene and Tropical Medicine is that of behaviour. But when I first started working on it, it really wasn't a common topic of study or discussion. Behaviour was seen as something ephemeral, something that started and stopped, and was very hard to get a grasp on what it was and how to measure it and what its causes were. But yet, behaviour is completely fundamental to everything that we are as humans and everything that we do. It's what distinguishes you from a vegetable. It's how all animals make a living. And actually, behaviour is what designed your brain. So let's just take a little example. Let's say 100 of our ancient ancestors decided they wanted to make a meal. And they went and collected lots of human poo to put in the casserole dish. Yummy, yummy, yummy. And they all cooked up a great dinner. 100 of their next door villagers said, oh my God, that's disgusting. Ugh, I don't want to go anywhere near it. Now, in your predictions, which of the two villages were going to survive and reproduce better? Obviously, it's the people who stay away from the parasites and the pathogens that are present in human poo. So the behavior of avoiding parasites and pathogens shaped the brains of our ancestors and made them want to avoid things that were disgusting. Hence, all of us have a healthy squeamishness in our brains. We have a center for disgust in our brain. So I spent most of the 1990s in Burkina Faso. The first part of it was a case control study trying to understand the risk factors for childhood diarrhea with Etienne Traoré, Bernadette Kanki, who's sadly no longer with us, Thierry Martins and Simon Cousins. We learned that it was behavior that mattered. Children's stools were not disposed of safely, and hygiene after handling stools was very poor. So how to go about changing those behaviors? The default that everybody suggested, as always, was health education. But our ethnographic research had showed that mothers already had clear and consistent understanding of diarrhea etiology. They knew all about konobuli, which in Jula, the local language, means running stomach. It was a symptom of various causes that mothers understood well, including contact with dirt and lack of hand washing. So mothers already knew how important hand washing was. They weren't doing it. That's why we set up Project Saniya. We designed a fun program of activities, including road shows on street corners with skits about poo and a roving team of potty promoters. The results suggested there were improvements. After 3 years, as you can see, the use of potties didn't improve much, but mothers washing hands with soap after using the latrine and after cleaning up the child's bottom improved dramatically over the 3 years of the program. What else did we learn during the time of Project Saniya? Well, we learned that there were serious problems about measuring behavior. Anybody who works in hygiene knows that if you ask somebody if they washed their hands with soap yesterday, they'll tell you, of course, they did. Perhaps if we'd observed what they'd actually done, we'd find that that wasn't true. So we needed better methods to measure behavior, particularly private hygiene behaviors like hand washing. But we also needed better methods for formative research. Too often, a formative research study would take 1 or 2 years and would be a highly academic exercise. We found lots of shortcuts so that we could turn a formative research study around in a few weeks or months rather than a few years, using techniques like daily scripting and soap inventories. The topic I've become most excited about over the third.
So with buzzword, I hand it to Arundhati for the next part of the webinar. Thank you.
Thank you, Kaushiki. And a very warm welcome to everyone again. What a great start to hear Val Curtis speak on the importance of measuring hand hygiene behaviors. So with this, I'm Arundhati Muralidharan. I'm with WaterAid India and also one of the co-organizers for this last webinar series. We have with us today a great panel that's going to dig into a lot of the issues that that came up during the Mentimeter quiz that Kaushiki spoke about in her presentation, that Nicola alluded to in his opening remarks, and of course that Val Curtis has also highlighted in her inaugural speech. So with this, I'll just quickly introduce our panelists for today. We have with us Dr. Saurav Chakravarti. He's with the Ministry of Statistics and Program Implementation, Government of India. I'm very delighted to have you with us today, sir. Dr. Saurav is presently working as the Deputy Director General in Survey Design and Research Division of the NSO. And he is in charge of looking after surveys like the multiple indicator survey, and surveys on drinking water sanitation, hygiene, and housing conditions. He also looks after the sampling design of NSS surveys, and he's been actively enrolled in several of the important rounds of the NSS, including the one that collected water, drinking water, sanitation, hygiene, from where we get hand hygiene information. We also are joined today by Sophie Boisson, who's the technical officer from the World Health Organization. Sophie is a technical officer in the Water, Sanitation, Hygiene, and Health Unit of WHO in Geneva. And her work has included estimating the burden of disease attributable to WASH and strengthening linkages between WASH and disease control programs. Ingeborg Krugert joins us from IRC. She's the lead for new initiatives, senior sanitation and hygiene specialist. Ingeborg has 25 years of international experience in development, much of which has been spent in the WASH sector. She's been leading the Asia and India country programs at IRC with a specific focus on sanitation and hygiene. We also have with us today Sumit Patul, who is the CEO and Research Director at Nirman. Sumit heads Nirman, a specialist evaluation, monitoring and policy research organization that he founded in 2007. And over the past 15 years, they've conducted numerous evaluations in the WASH sector in India, which has differed in focus on water, sanitation, hand washing, menstrual hygiene. They've looked at different approaches to behavior change, infrastructure, capacity building, and they've used different methods such as randomized controlled trials, quasi-experimental, and cross-section studies. We're also joined today by Robert Rebelbis, the Associate Professor from LSHDM. Robert's work over the years has focused on understanding the determinants of water sanitation and hygiene and WASH-related behaviors, and developing and evaluating WASH and WASH behavior change interventions at a household, community, and institutional level. And he's also a member of LSHDM's Environmental Health Action Group. We're also very pleased to be joined by two colleagues from the Aga Khan Development Network. Jairam Pathak is the state team lead for UP, the Aga Khan Foundation. Jairamji has more than 15 years of experience in the areas of WASH, maternal and child health, and nutritional projects. He currently works very closely with the Swachh Bharat Mission and PRI departments, Jal Nigam in Uttar Pradesh, specifically on a range of WASH interventions. His area of expertise is large-scale program management, advocacy, behavior change communication, capacity building, and monitoring and evaluation. We're also joined by Anita Mia, who is the head for environmental planning at Aga Khan Agency for Habitat India. Anita has 27 years plus experience in the social development sector, and she has a very strong passion for community-led development. Her skills are underpinned by the hands of management of diverse initiatives such as water management, environment, sanitation, climate change in the social development space. Anita sets herself apart by her passion for building community-focused, community-centric development and innovative problem solving. So a very, very warm welcome to all our panelists. In today's panel, we really hope to dig into a range of issues that we've discussed. We want to hear about measurement, monitoring, and evaluation of hand hygiene behaviors from perspective of large-scale surveys, qualitative methodologies, looking at behavior change, and of course, programmatic monitoring. So we're going to try and cover all of this. We have a number of great speakers, so we're going to request each one of them to keep their interventions for about 6 to 7 minutes. And after they speak, we'll open up for a Q&A. Meanwhile, if the audience has any questions, please do post it in the Q&A box. And I request all our panelists to have a look at the Q&A box. And if you want to answer any of those questions in that Q&A chat box, please do so. But we'll also open up at the end for about 15 minutes Q&A. So we're going to start off our discussion where Kaushiki left off her presentation. And our first question is for Sophie from the World Health Organization. And Sophie, Partially alluded to the JMP framework, but we'd like to hear from you as to how country-level data is collected from across countries and it feeds into the larger JMP report on households, schools, healthcare facilities. How can we look at collecting more robust, better data on hand washing in different settings to give us more accurate national picture and even a global picture? We also want to hear from you, given your role at WHO, on the links between hand hygiene and health outcomes from a measurement perspective. Since you lead the updates on the global burden of diseases attributable to WASH, the audience can really benefit from hearing about how WASH is assessed as a determinant of health outcomes. So over to you, Sophie.
Thank you very much, Arundhati, for the introduction and for those questions. Good morning, good afternoon, everyone. So on your first questions about how the country-level data on hand washing is feeding into the GMP reports. So first, I'd like to start by saying that the GMP use national data sources that are representative at the national level. Then the GMP compile the primary data sources and produce some estimates using modeling techniques. Then the preliminary estimates are then shared with national authorities for consultation before it gets published in the reports. So just to flag that it's very based on country data and it's also validated in consultation with the countries. So if we take the data that are available for India, as it was mentioned already to some extent in the introduction, at the household level, there's a few surveys that have collected data on availability of hand washing facilities in the home. So, for example, the 2014 rapid survey on children, and the 2016 National Family and Health Surveys. In the latest NHFS survey, they found that 80% of households in urban areas, as well as about half of rural areas, had hand washing facilities with soap and water. I mean, almost all of the households had places for hand washing, but this survey showed that a lot of them actually didn't have soap and water. There's now a more recent survey, MSS, published in 2018. So we're in the process of updating the household estimates. So we will be including those new results in the upcoming estimates. In healthcare facilities, the GMP has relied on the Kayalpak survey from 2018, which were from hospitals. And they found really high availability of hand washing facilities in hospitals, but they also found that it was more likely to find hand hygiene facilities at the point of care than near toilets. In schools, the best and most recent data are from, as it was mentioned in the introduction, are from the Swash Vidyala Purashkar surveys in 2017-2018, as well as the education sector's MIS, which have really shown that nearly half of schools don't have hand washing facilities with water and soap for use after toileting. So how can we better collect hand washing data? I just wanted to go back to the point around the difficulty of getting accurate data on actual hand washing behaviors. Of course, asking people about their hand washing behaviors does not give accurate data because people tend to over-report their hand washing practices. So a more accurate way would be conducting structured observation, which is really watching people for hours and recording, when there are hand washing opportunities, and seeing actually if they are washing their hands, but also whether they do so effectively, whether they use water and soap, and whether, and so on. But of course, that's very difficult, that's very intensive and difficult to get nationally representative data for. So the GMP doesn't actually collect data on hand washing behavior. It collects data on the availability of hand washing material in the home, which has been shown to be a good proxy for actual hand washing practices. Again, there's some risk in the household survey that people will over-report even the availability of hand washing facilities with soap and water. So really the GMP's preferred method is to have the surveyor themselves observe the hand washing facility and to record if soap and water are available there. And increasingly, household surveys are including this kind of information, like through observations, and now getting nationally representative data. I just wanted to also note that obviously the GMP is collecting information on the basic service indicators, but they may not fully capture all the hand hygiene aspect needed for health and well-being. And so, as you will see in the reports and also in the core questions, there's a set of, in addition to the list of core questions, there's a set of additional questions and additional indicators that can be used to capture those aspects, for example, in national monitoring systems. And as it was finally, I just wanted to say that, as it was said before, monitoring is one of the key, is a key element as part of the hand hygiene for all initiative. And so through the work that GMP is doing, we'll be able to propose new guidance on how to measure those practices. Now, the second question that you had was around the connection between the hand hygiene and health outcomes. Obviously, we all know that hand washing is essential for protecting against many diseases, well, obviously including diarrheal diseases, but also preventing transmission of respiratory diseases, as we've seen the prominence of hand washing to prevent and control COVID-19. In healthcare facilities, effective hand washing, effective hand hygiene is really the primary measure for prevention of healthcare associated infection and also the spread of AMR. So the WHO produces estimates on the burden of diseases from inadequate wash, including hygiene, at country, regional, and global level on a regular basis. These burden of disease estimates draw on three sources of information. So the first, the systematic reviews of the scientific literature on the risk of disease linked to unsafe hygiene. The second, the data on the people washing hands with soap after fecal contact, and that data is actually calculated using based on the GMP data on availability of hand washing facilities. And finally, it uses the disease statistics, so the disease-specific causes of mortality and morbidity. So these estimates are the basis for the SDG target indicator 3.9.2, which is the mortality attributed to unsafe wash. I just wanted to mention that the last BOD estimates attributable to wash were available for the year 2016. I mean, it was found that inadequate hand hygiene was associated with 165,000 deaths from diarrheal diseases, but also 370,000 deaths from acute respiratory infection. So we are in the process of revising these numbers for the year 2019. So these new numbers will be coming out soon. So with that, I will end my intervention and hand over back to Arundhati. Thank you.
Thank you very much, Sophie. And I think it's a great segue for us to go from from looking at how GMP looks at measuring hand washing, in terms of the availability of a hand washing facility on premises that has soap and water, to looking at how large-scale surveys in India that are run by the government are capturing information and data on this important indicator. So with this, I'd like to turn to Dr. Saurabh from the Ministry of Statistics and Program Implementation, and to ask that, to first of all acknowledge that MOSPI and NSSO has played a really vital role in implementing large-scale development surveys and in asking a lot of important questions, especially on water sanitation and hygiene over the past few years. So what we'd like to hear from you is, can you tell us and walk us through how you look at incorporating indicators related to hand hygiene, hand washing in these surveys? How have you picked and selected the most relevant ones that can give us the needed information? What are some of the challenges that you faced, and how have you been able to overcome these barriers in data collection? Moving forward, we'd also like to hear some of your recommendations on how we can strengthen hand washing and hand hygiene related indicators in these large scale surveys. And lastly, if you have any reflections on innovative technologies that you have used or that we should use as we look at collecting large scale data on hand washing. Over to you, sir.
Good afternoon to all of you. Thanks, Anandati. So I will discuss some issues on that we have faced and we have experienced in our service during 2018, July to December. As also I have posed some queries maybe that we have come across, or I am thinking about the issues, overall issues of this hand washing, or as per se hand hygiene. So Aditya, can you go to the next slide? I am also actually, we two are there in from our ministry. Mr. Dijesh Tiwari is also Deputy Director General. He is looking in the field, looking after the field, sitting in New Delhi. So he is also with me, but I am presenting on this behalf of home. So the discussion points of this, actually what hand hygiene means, then this is the border of the discussion. Is it only the hand wash or it's something else? Then what to measure, then how to measure, that we actually came across while discussing. I will come to that point. Then scope in this large scale sample survey like NSS, that we experience these things in NSS 76 now. And whatever the challenges or maybe the way forward that I will touch on. Next, please. Well, so the first, the foremost thing is that what is the definition itself of the hand hygiene or hand wash per se, and how we conceptualize these things in our large scale samples. Now, let me tell that this in NSS the practice is that in every survey we generally conducted a working group has been constituted by National Statistical Commission. And this is a very independent group headed by some academicians and all other line ministries and international agencies are the body of that working group. For this 76th round, that's where we have put some questions on hand washing. UNICEF was a member and WaterAid was a member of that working group. Even WHO is also the member of that working group. And the working group was chaired by Mr. Partho Mukherjee, so Center for Policy Research in New Delhi. And there are other, all the line ministries, Ministry of Drinking Water Sanitation, All India Institute of Health and Hygiene, Ministry of Health, all those are the members. So whatever the questionnaires we have finalized, it's within the discussions of in the working group. Several meetings are there. I think Kaushiki also attended one meeting here in Calcutta. That is the first meeting, and we come up with some questions on the hand washing. So basic questions that we discussed on that, how to measure and what to measure as such. One point I'd like to mention is that since NSS is actually taking many requisitions from different ministries, that particular survey was on drinking water, sanitation, hygiene, and housing conditions. So as you can understand, there are 4 sectors and different ministries are involved. All requests we have to encompass and incorporate in a particular round. So it is not a focus survey for the hand wash or hand hygiene per se, which perhaps may be required for a deeper insight of this important topic. But it's not possible in a service of NSS to deliver a survey only on this at the pan-India basis. Because we have to consider the requirement of housing ministry, we have to consider the requirement of drinking water sanitation ministry on the several aspects, which is quite linked with the hand wash as well as hygiene in general. So next. So this is, I think there is a typographical error. It is NSS 76th round. So it was conducted in July to December 2018. So 2 questions actually we have put in the hand wash section. It is that whether the household member regularly wash their hands before meal, and whether the household members regularly wash their hands after defecation. So initially we had thought about the hand wash before meal, but somehow in the working group, many persons, many experts also asked about to put the second question also, to see what is the practice actually in the India, because go to the next slide, Arita. So you can see that we have used these codes. That is very important. We have actually 4 codes. In the ES section, we have 3 codes. This is ES with water and soap detergent, then with water and ash mat or scent, then with water only, and no is the 4th. So as far as defecation is concerned, one of the important consideration was on the code 3 itself, to see what is there in the code 3, because it is linked with the general hygiene as well, not only the hand hygiene. And this water and soap is also obviously a important code. Also in the India, there is a practice of water with the ash and mat. But how we use the definition? So what is the hand wash means? So that is a very topic that we have discussed a lot, deliberated a lot, that how we define the hand wash, whether it is a single hand or it is a double hand. If it is single hand, then how it is. If it is double hand, then how it is. So we have finally come up with this is the definition used, the screening of both palms, front as well as back side. It's very important, not only the front side, and all the fingers with water. So these are the catch points, both palms, front, back, all fingers with water. That is the definition we finally come up with. And one of the point is that this soap and detergent, it's what it includes. It includes liquid soaps and hand sanitizer, wet and dry tissue papers, etc. So we thought that I thought that these 2 points will be of interest, because the interesting thing about the definition of itself. Next slide. So now what's the coverages generally? You see the households, a very large number of households that we have covered. It is about 1 lakh households in India. We have covered, and person is surveyed about, say, 4.6 lakhs in India. This survey was conducted, and these particular questions, as you can understand, these are household-based questions, and that we asked about the practice and how we say that yes or no. If it is, we use the criteria that's generally used by NSS. It's called majority criteria. It is the majority of the household members. What is their practice that we know? It is not the individualistic one. So it's not the person-specific questions. It's a household level questions. Now, what is the results? As you can understand that almost all persons, all households reported they wash their hands. But this you must understand the importance of the with water only questions. That is very prevalent in as far as NSS survey is concerned, 60% in rural area they say that with water only they are washing their hand. The penetration of this water, soap or detergent, it's a still it is a urban phenomenon more. It is about 56%. That is out of 10 people. But if you look at the 1/4 of the rural households are actually using the soap and detergent. Others mostly about 70% of rural households, more maximum members of their households are using water only. And the defecation case also, there is very interesting things that we have found it at that about 13% of the households said that they use the water only after defecations. This is not only the general health purposes and hygiene purposes. So it's an interesting fact. It's okay in water and soap as we expected. It is higher in case of defecations, but still there are some issues, some learning phase about the with water only. So the next slides. So now what is the challenges? I think I should share on this because what is the workable definition? It is things because we have considered many queries. We obtained many queries from the field also. The field across the India, different cultures, different structures. So the queries like that if one member is doing that, then what will be our coding and etc. So also the measurement issues, we have some things. Whether the before meal is enough, whether the after meal that we also have to consider. This after lattering is only things, then with the both hand or single hand, and also the frequency, as I think Kaushik also covered this. Now, what is these things is that how we go for the majority of the households members practice. Now, we didn't ask about the frequency. So that maybe a deeper insight is required for that, or more questions will be required for that. And then how to measure like importance of how, this is the way forward, I think, in the present scenario, how people feels about the importance of hand wash. That is not, we didn't ask it because it is not a very focused survey on the hand wash itself. It's a more general survey of the drinking water, sanitation and hygiene as such. But this question I came when I was preparing these slides, it came to my mind that this may be a very interesting thing, but what people's perception is there. Because before meal, many people were saying that it's observing that they use only water. So what is the perception about use of soap? Is there any cultural differences, or whether there is some behavioral patterns that maybe think of to do some in-depth analysis on that. And lastly, I think what's important point is that whether it's a household level measure or it's a individual level measure. And this varies with person to person, or it's okay that you have to start with it's a household kind of things using the majority criteria maybe used. So I think that's all. Thanks for your patience.
Dr. Saurav, thank you very much. I think I really liked your last slide because I think the challenges that you've listed is something that all of us who have been in research looking at hand hygiene can really relate to. And I think we're all struggling with the same challenges that you put out. So thank you very much for really highlighting this for all of us to kind of ponder over. Thank you, sir. For that. And also, I think that it's very helpful to hear the systematic way by which you're approaching these large-scale surveys. Great insights. So thank you for that. If anyone has questions, both Sophie and Dr. Saurav, please do put it in the Q&A box and we'll try and get to them either by typing our responses or at the end of our panel. So with this, we move on to Sumit. Sumit, you and your organization, you've been heavily engaged looking at using impact assessments and quasi-experimental designs to study various aspects of wash, including hygiene. So we'd like to hear about how impact assessments have been used to measure hand hygiene, especially with the focus on assessing interventions. What's worked well according to you? What are some of the challenges that you faced and the solutions that you would recommend to all of us? And if you have any inputs on the use of innovative technologies to undertake these surveys, measurement-related tasks, then please do shed light on that. Over to you, Sumit.
Would I get my slide? Yeah, great. So thank you, Arundhati. Let me dwell immediately into the questions you asked me. I'm going to answer this question in context of a very relevant impact evaluation we had done for UNICEF in Assam. So we are talking a school-based group hand washing program called DHAL, the daily hand washing for an ailment-free life. And it was amazing when Nicholas talked about how Swachha Vidyalaya Puraskar is also measuring hand washing, especially the infrastructure part of it. A lot of similar work was done even in this evaluation. The program intended to change behaviors of students in a group setting, and it expected that the children would be change agents to change behaviors even at their home. So what I'm going to focus is not on impact evaluation design, but more on our experience and challenges on the measurement. Okay, next slide, please. Next slide, Aditya, please. Yeah. So three important ways in which the measurement of hand washing as an outcome differs from, say, the large surveys like Dr. Chakraborty just talked about, like NSSO or NFHS would do, is that impact evaluation is going to make the outcome, the primary outcome, hand washing in our case, a king. So we would ask hundreds of questions on hand washing, knowledge, attitude, practices, measure the behaviors in different ways. We can afford to do that. Our sample size is going to be a lot limited than a national survey or a regional survey. So we can afford a very credible and very, breathe down their neck kind of a supervision to ensure credibility and quality of the fieldwork. And finally, the focus is going to be on bias control such that the measurement bias or the errors are not different or not differential between the treatment and the control group. As we all know, the impact evaluation is about proving causation, which is done by proving comparing the treatment and control group. So one thing we ensure is at least the bias, even if it is a bias in measurement, it should not be differential between the three groups. The way we have been doing is first, we try to really make the primary indicator something more objective. There are 4 ways we have attempted, and I'm going to talk about 3 which we have used in DHAL evaluation. Observation, which is what we have been talking about, observation of facilities and even practices. We can even observe and measure and count hand washing instances, again, because we can afford to in impact evaluation. We could put sensors in the soap, and this was done not part of this study, but other studies. There could be some challenges, one specifically being we cannot link the acceleration-based soap sensor to a particular person. All we know is the household is using the soap, okay? Third can be the secondary data or the records at the school level. What we wanted to attempt was get the data on the actual number of soaps the schools have procured and used, and then using this 0.35 grams per hand washing instance, back calculate how many hand washing instances are there on average per student in the last academic year, okay? And the final objective measure we have been using, and again used in DHAL, was a hand rinse sample. You literally go for the main thing, like, is the hand washing really getting rid of the fecal or other contaminants, okay? Obviously, we can't often rely on only objective measures. They can be expensive. So we go even on subjective. This is a typical recall-based measures we are talking. And one thing we do is we do not follow the typical, the demographic approach of going from knowledge to attitude to practice. We actually flip the order. We first ask about practice and then come to attitude and perceptions and knowledge. The reason we do that is we don't want this knowledge or perception or attitude questions to sensitize the respondent to giving us a socially desirable answer. Another thing we do to measure if there is a social desirability bias is to ask a practice which is not related to hand washing, or something, a practice which not be changed by the intervention. For example, in our case, it was whether you openly defecate. The intervention was not about defecation practice at all. And we did not expect it to change between the treatment and the control group. And final is the list experiments. This is a way of getting, trying to mitigate the social desirability bias in sensitive kind of topics, okay? I don't want to discuss more how it is done, but this is a very credible method. And obviously we have to triangulate all this data. I'm not going to take a lot of time how we, next slide, please. Yeah. So again, we talked about the children recall. What we did, basically, we asked the recall two ways. One was prompted recall, something like an example NSSO did. Did you use, say, soap and or mud or ash to wash hands? That's prompted. Versus spontaneous. Did you wash hands with what? Okay. So one is spontaneous, one is like prompted. We tried both. Our learning was, I'm glad we asked both, because there were big change in the type of answer we get. Just a simple change in wording would give us a different answer. Okay. And obviously these wordings have to be tested a lot in the field, and how you introduce the survey can bias the responses. Okay. Second, our learning was, while schools were expected to maintain the data on soap consumption, many did not. So that the lesson was, when we come up with measurements, let's not assume that whatever is prescribed is actually being practiced. Okay. So we had to then rely on school teachers' recall that how many soaps did they actually consume. The observations, many people have talked a lot. I'll make one point. We did two observations. We did a 2.1 when we immediately arrive in the school, and one just before the midday meal, which was the main instance we wanted to measure hand washing at. And we saw a quite different result. By the time the school learned that we are there for doing the hand washing survey, the observation of water and soap went up by about 15 to 20 percentage points. So yes, there is this strong observer effect, and perhaps there is some protection of soap, because the teachers mentioned that they will keep soap out only during the lunchtime, because they want to protect it. Next slide, please. The hand washing behavior actual observation, we gave coupon to all the students who were present in the school from grades 1 to 5. They were kids. So they were given coupons with a number and a color code for as per sex, guys and girls. Okay. And we told them that we are going to collect this coupon box and give them a toffee. So we tried to ensure that we did not bias them about this coupon is for your hand washing. 5 to 6 animators were placed at different strategic points to observe how many people are washing hands, and then collect the coupon box back from them and slot them in 3 bins, whether washed hands with soap, or did not wash hands. So, and this way we could get for all the students in the school what exactly they did before the midday meal. The big learning here was, children are not going to wash hands if midday meal is not going to be served. Our pilot had shown that about 95% of the schools will serve midday meal every day, but in reality that did not happen. So we lost 30% of our data. So when you come up with the learning ways, when you come up with a measurement protocols, be aware that, again, what we assume is true based on secondary data need not be true, even from the monitoring systems. And the hand microbial contamination was supposed to be a very robust objective measure. That one, and we had 2 samples per child, midday and just before the midday meal. Okay, so the design was perfect. Where we lost was the use of the H2S test kit. We procured them from PHED, which is Public Health Engineering Department, and unfortunately the quality of vial was such that we had about 50% of false negative rates. And when you have such a big data problem, you can't use it. Again, so in impact evaluation, and many of you know, they can get really expensive because the kind of money you put on measurement. And when we try to do, for lack of better word, a jugaad, I paid very dearly for that, because we did all these like amazing like test kit, on-field lab, but we could not actually use the results because of the final linkage. The test kit was not good. So the big learning is, if you are going to do something as rigorous, rather put a little bit more money and do something that is truly credible, go to a lab. So these were our learnings. And just to final slide, Aditya, final slide, please. Yeah. Just so that you see the numbers, how it changed. The first column is the way we measured it. Observation, OBS is observation, SCH is school, child, teachers. So you get different data. For example, let's look at this. Suppose when we asked child to recall whether soap and water was regularly available in school, less than 20% in control group said yes, it was available. But when we actually observed, it was about 50 to 60%. When we asked child to recall this spontaneously, whether they washed hands with soap and water before the midday meal, it was 16% usually. But when we read out the option, then that went up to about 39 to 40%. So how we ask questions did matter. And when we asked the negative control, we did not see a difference. So then we also got some idea that perhaps the bias was not differential between the treatment and control. Of course, we had to triangulate all this data in our paper, in our report, to say which direction of effect it might be. Some effect could be underestimated because of the bias. Some indicator might be overestimated, the difference. So we had to triangulate a lot. So the big learning and the good practice is, at least for impact evaluation, having multiple indicators to triangulate. And this is it. That's it. Thank you so much.
Sumit, thank you very much. I think that you've given us a great run through of the different measures that we can use. And especially, I think that you've really broken it down for us on objective measures, asking behavior or practice related questions before we get to those knowledge level questions, looking at soap consumption and expenditures, looking at microbial contamination. And very importantly, I think you've also tried to help us understand how we can begin to triangulate all this data. And I think, again, like Dr. Saurabh, what you've also done for us is shown us where sometimes this doesn't work, or what's the challenges that we're facing. So the real life, real world issues with measurement, we want to go for the most robust ways by which we can do this. But I think it's important for us to know what are the potential pitfalls as we're going into this. So thank you very much for this. I think, Sumit, both for you and Dr. Saurabh, there are questions in the chat box related to what are the types of questions we ask, how do we ask practice questions before knowledge questions, as well as this whole issue of data triangulation. So if you'd like to have a look at that. Now, we've heard a lot about large-scale data collection, but it's also important, I think, as Nicola flagged right in the beginning, for us to look at how we can understand hand hygiene behaviors more qualitative ways and really dig into why people do what they do. And here is where we'd like to hear from Ingeborg from IRC. Now, IRC has used qualitative methods to measure hand hygiene in other countries. And they have several insights from Bangladesh, Nepal, Bhutan, and in Indonesia. And we'd like to hear from you, Ingeborg, about what you've learned from these other countries and what are some of those lessons for India. And alongside qualitative methods, surveys, how can we incorporate these, quantitative methods, how can we incorporate a qualitative lens? So over to you,
Ingeborg. Thank you, Arundhati. Yeah, I would like to start with the next slide, and the same as Kushiki, because I think we owe a tribute to Val Curtis. I think she's my hand hygiene guru, and I think she's the guru of many hygiene enthusiasts. She continuously worked on showing the importance of hand hygiene to combat diarrhea and also other diseases. And yeah, time and time again, it is really, really necessary, because all the time hygiene gets back out of the let's say political agendas. Now with COVID, it got back in a little bit, but yeah, we really have to make sure that it keeps high on the agenda. And I think Val Curtis did a huge job in that. She recently passed away, very sad, but I think her legacy lives on. So I wanted to start with Val on that. And then next slide, I think she also contributed a lot to making sure that with the SDGs that we got hand washing as a separate indicator. And I don't think we can underestimate the importance of really having hand hygiene and hand washing as a separate indicator. As Kushiki also shows in the next slide with the JMP data, because having being able to show progress for hand washing or the lack of progress, that's really a first step for improvement. Here you see India shows like a 50 to 75% proportion of people with a hand washing facility. In the Mentimeter, if those were already there at the beginning of this webinar, reliability was a big word in the word cloud. So some people have some doubts about reliability. I think that's a good thing. So because having data like this, starting with the national data, primary data available, secondary data available, you can start having this discussion. So, and then have the discussion as we do here. So how is this measured and can we improve? So there are various other institutions already looked into the different approaches we have. We already discussed a couple of them here. So what are the biases of the different approaches? So, and I think Robert may also dive into this a little bit more. I think the key thing for us to know, and especially also India, is why are you doing, why are you measuring, why are you monitoring progress? It's different when you monitor progress because of a study and you want to see if a certain method is working, or if you really want to know if there are certain groups of the population or certain areas where there's in particular a problem with hand washing. So in that case, you have to come up with approaches that are feasible to carry out at large scale. And the things mentioned here in this slide is mainly like observations by others and by self-reporting and consumption of hygiene products. And Sumit was also mentioning that. So next slide. So an example IRC was involved in is the monitoring of hand hygiene in Indonesia. So in Indonesia, this was a joint program with CIMAVI, funded by the Dutch Embassy, and Plan International was one of the implementing partners. I think there is the only example I can recall IRC is involved in where it was really possible at a very large scale at house to house level to do a monitoring exercise. The first 4 years of the program was on capacitating staff at government level, and the second phase, many of the district officials took over that exercise and incorporated that in their own monitoring system. And that is, I think, what Koshiki was mentioning, mainstreaming hand hygiene data collection. And that way they were able to do the monitoring for like 1.5 million people in 9 districts. So really house to house, so not on a sample basis. And that allows the district officials, the government, to see which areas really need special attention or where to improve. This is based on observation, so really household observation. Is there a place where people can wash their hands? Is there running water? It was also linked close to the toilet, so that was an important element. And it was done initially on a 6-month basis, using very simple Excel sheets that were then sent to the community did it themselves, and it was sent to the district officials. Now I think they turned it back to once a year with these 1.5 million people. And talking about reliability, validity, a next step, I think that still should take place also in order to validate the self-reporting data, is on a sample basis do a more rigorous study to see if these findings are more or less aligned and reliable. So that is how you could use it. So really at a large scale, and then once every 2 or 3 years have a validation study on a sample basis. And in those sample based studies, you could then also include these automated monitoring options like sensors in soap. That was done in Bangladesh with BRAC also, where they do monitoring on a sample basis, where they could see for like 30 million people if the hygiene, hand hygiene program worked or not. And it was validated by Emory University to see if that measurement method was indeed valid. I didn't mention BRAC here with that example because it is on a sample basis. So we know the program works, but we don't know exactly where the people are, where it's not working, because it was really on a sample basis. And I think the Indonesia one really shows the possibility of doing this at a very, very large scale, like in India. I think, yeah, and then maybe I would like to end with the sustainability issue. So does it sustain? There are very, very limited studies that look into programs, let's say 5 to 10 years after, to see if people still wash hands. So did it really sustain? Some of these studies start now with the CLTS, so on the use of toilets for hand washing. I think it is more Samir, if anyone has examples, I'm very happy to hear. There is one example by Sandy Cairncross, and that's already more than 20 years ago in Kerala. And that's the next slide, where we could see indeed when the hygiene interventions were intense, so not a one-off awareness campaign, but when there were intense hygiene interventions and support from the environment like authorities. In that case, even up to 9 years after the intervention, it did show that there was, that people were still washing their hands. So I think this was really a good, positive outcome. And I would love to see if there are more studies like this showing the sustainability of hand hygiene. I would like to stop here and see if there's any questions.
Thank you very much, Ingeborg. And again, you've highlighted a critical point for all of us, which is looking at sustainability of hygiene practices in the long run, something that I think that we don't, our research doesn't take enough cognizance of. So something for us to think about. Again, please, for all our panelists, if you could look at the great questions in our Q&A box. So please do look at them and answer them if you can. Without further ado, we're going to get to Robert right now. So Robert, LSHTM has been a pioneer on working on hand hygiene behavior change and has a very systematic approach towards research to unpack the drivers and the motive drivers of hand washing and hand hygiene behaviors. Can you tell us and walk us through your approach, which often combines literature reviews, formative research, qualitative research, as well as quantitative survey research? So tell us about how you approach this. We'd also like you to shed a little bit of light on something that we all struggle with, which is to really measure social norms and emotive drivers of hygiene behavior. So how do you go about doing this? Over to you, Robert.
Great. Thank you very much. Just to, kind of one word here that, it's very, very heartening to see the outpouring of support and recognition of the massive contribution that Val Curtis has made, who was at London School of Hygiene and Tropical Medicine, and was one of the key people that really developed the system that we here refer to as behavior-centered design. And so thank you all very much for that. And she's a large loss to hand washing community globally, but a particularly acute loss here at LS.